Joining me today is Dianne Berryman, Senior Project Officer at Integrated Care Department of Health Victoria. She'll be speaking at IR's Reducing Hospital Readmissions and Discharge Planning Conference, which takes place on the 25th to 26th of July 2011 in Melbourne. Hello Dianne, thanks for joining me today.
Hi, how are you?
First of all, how has the Hospital Admission Risk Programme developed since its inception 10 years ago?
The Hospital Admission Risk Program, which I'll be calling HARP, began as pilot programs as part of Victorian Hospital Demand Management Initiative. What that meant was we had 87 plus projects in various settings throughout the state, all working with little cohorts of people to improve their access to good quality services with the intention of decreasing demand on hospitals. When that was evaluated after 3 years, there were some very good outcomes found from those pilots, but the decision was made to mainstream them into larger programs that were run through health services so that we could get a little bit more consistency and equity of access across the state. After they were mainstreamed into 15 programs, there was further expansion into rural areas so that some of the sub-regional cities were also funded for HARP programs. And then more recently, a year ago, we were able to expand into smaller areas again so that we now have 35 HARP programs across the state.
And what makes HARP effective, particularly when compared with readmission programs that other hospitals are employing?
The core elements that were identified partly from the evidence base and also from the pilot programs is really the focus on the importance of care coordination. So most of the people that are those frequent presenters that HARP caters for are people who might already have had referrals to various services, but there's so many different services involved and it's so complex and confusing for the clients that the system doesn't come together for them. It all falls in a heap and they land back in hospital. So what HARP provides is a care coordinator who links all those services together, looks for where there's gaps, addresses what the barriers are for the client and helps pull it into a single integrated plan that can then be sustainable in the primary care sector. The other elements that HARP is able to bring in that helps its effectiveness is a timely access to specialist medical care and also a big focus on partnerships between hospital and the community sector. In terms of how similar it is to what's happening in perhaps other states of Australia, I don't have a full understanding of some of the other programs, but my understanding is that Western Australia has something similar, but with perhaps a little bit more of an emergency department focus and a 24-hour sort of approach, and perhaps a little bit less of the community-based care coordination. And I believe New South Wales has something similar that's probably a little bit more primary care focused with a lot more of that care coordination conducted through GP practices. So we're all heading in the same direction with slightly different models. In terms of outcomes, I think that's a bit of a challenge for all of us to assess what's the most effective way to do it.
And can you run me through some of the outcomes of the programme, particularly based on the findings of local evaluations?
Evaluation is always a challenge, I think, for chronic disease management programs. It's very difficult to do a robust evaluation in terms of with a randomised control group that can give you that really strong gold class evidence. What we have been able to do with some of our local evaluations is some very good models where they've been able to do evaluations with some form of control, whether it's not necessarily a randomised group, but effectively getting a comparison that gives them strong data. For example, one of the HARP programs that has a respiratory stream looked at evaluating numbers of ED presentations, hospital admissions and number of bed stays for admissions for the group of clients that had participated in their respiratory service compared against the people that were also eligible to participate who had declined. Not a randomised group, but it does give us at least a comparison of a very similar group of people. And from their outcomes, the patients that had participated in their HARP program had 10% less ED presentations in the 6 months after participation compared to the control group who had a 45% increase. The group that participated in HARP had 25% less admissions compared to the other group that had 41% increase, and where they had admissions, the HARP group had 18% less days in hospital compared to a 51% increase for the control group. So really quite a strong difference.
And can you outline the introduction of a monitoring and evaluation framework?
As I said before, evaluation is very challenging, and introduction of monitoring targets for a program like HARP has some risks involved. It potentially, when you apply targets, services tend to develop their program around meeting the targets, and we've been hesitant to do that because we really wanted a program that was developed around meeting client needs, and that flexibility to be very client-centred was very important for HARP. However, 10 years down the track, we do feel like we can bring in targets without that risk, and that's to ensure that we're doing that. We've kept a very strong focus on what are the aims and objectives of HARP and worked very closely with the program managers of HARP throughout the state to ensure that the targets that we are putting in place and the key performance indicators that we're monitoring are actually going to support the program rather than potentially be a perverse incentive to move away from that care coordination focus. What we are planning to do is commence monitoring of the selected key performance indicators that we've come up with through that collaborative process from July, and that'll also be supported by a evaluation guide. So the evaluation elements won't be compulsory across all programs because different service models in different local contexts may want to measure slightly different outcome measures, but the guide will at least enable us to have enough consistency across those local evaluations that we can do a meta-analysis of evaluations statewide and get some really strong data to then in the future be able to compare models across the states of Australia and identify what is really working best.
Dianne, you're speaking at IAR's Reducing Hospital Readmissions and Discharge Planning Conference, which takes place on the 25th to 26th of July 2011 in Melbourne. What would you like delegates to gain from your presentation?
First of all, an understanding of the hospital admission risk program. That's certainly the key reason I was coming to talk. But part of that, I think, is that understanding of the need for a flexible approach to care for this particularly complex client group who do tend to present frequently to hospital. That need for a really quite broad and proactive approach to meeting client needs, not just addressing the needs that they're presenting with right at that point of time, but looking broader at what are all the factors impacting on health for those clients. And additional to that, the importance of a system-wide approach when you're working with people with chronic care needs.
Dianne Berryman, thanks for your time today. We're looking forward to your presentation in Melbourne in July.
Thank you very much.